CataractCoach.com. Cataract Quiz. What if you do not decompress an intumescent white cataract? What happens? What's the challenge? So I'll show you two different cases. This is case one. Watch carefully. Look at the lens cortex, the lens capsule. As we inject our viscoelastic, you can see there's movement in that lens cortex because it's liquefied. Hence, it's an intumescent white cataract. It's fluid-filled. So normally here I decompress, but we're going to try to avoid that just to see what will happen. Let's make our main incision here. And can we do a regular capsulorhexis? Now there's going to be some pressure pushing forwards and therefore causing the capsule to want to run out. So we'll start the rhexis. So far so good. But look what happens. As we start to tear the rhexis, I'm bringing it inwards. It has a tendency to want to run out. So much so that right about here, I'm going to have to resort to the little maneuver just to rescue it, to bring it back in. And the longer we take, the more this posterior pressure pushes forwards and risks a run out of the capsulorhexis. So even here at the very end, look at the direction in which we're pulling. We're trying to get it completed, and somehow we manage. Woo, finally. All right, it worked. And the patient did great. But let's show you a different way, a better way. Here's a different patient now. So on this patient, we're filling up the capsular or the anterior chamber to flatten the capsule. And that's a good fill. We've stained the capsule trypan blue dye. We want to put even a little bit more viscoelastic because I want the pressure in the AC to be higher than the intumescent pressure in the bag. Now we're going to get a needle, an empty 27 gauge needle on a 3 cc syringe. The syringe can be empty or full of balanced salt solution. We're going to aspirate with this. We're not going to inject. So we're going to poke in the center here, bevel down. Look at the position of that bevel. Go right in the center of the lens nucleus and poke in and aspirate out. Very nice. And that's going to decompress that capsular bag. We can even rotate the nucleus. Now, I've showed you videos of many surgeons using this technique. Some Brazilian surgeons. I've shown you my friend Lucan Michev. He does this beautifully. Lots of surgeons do it this way. It is an important step. So I think for an intumescent white cataract, you either do a double capsulorhexis technique or just do like we've shown you here to decompress it using a needle. Now, with the capsular bag not under pressure, it's very easy to create our normal capsulorhexis. And watch the forceps here. We can just do things normally. There's a lot of control. There is no pressure. It doesn't want to run out. It's a nice, easy, controlled system. And we're able to create a beautifully round and centered capsulorhexis. Again, risk of a capsular run out are very, very low here. And now we've completed that, and you can see it's an appropriate size. Looks great. Remember, in these cases, there's not much need for hydrodissection because the lens cortex is already liquefied. In fact, in this eye, as we inject some fluid in there, you see a lot of it comes out. So we'll finish up this case just to show you our technique is going to be a chop method. Chop that nucleus into smaller pieces and emulsify it down, and everything will go just beautifully. So we'll speed up this portion of the video. So when you have these intumescent white cataracts, remember, the best way is to decompress the capsular bag. Release the pressure that's built up in that capsular bag, and you can do that with needle decompression. We've shown you ways to use phacoaspiration with the phaco probe or a needle on the IA probe. We've even showed you the double capsulorhexis technique of making a baby rhexis first and then finishing it with a larger rhexis. But whatever you do, do it safely and give your patient a beautiful outcome like we've seen in this video here. Thanks for watching. Check out our website, CataractCoach.com.